Dental emergencies endanger life, function, tissue, or cause uncontrolled bleeding or severe pain. About 2 million ER visits yearly. Clear definitions help triage dental issues before they escalate. Which dental problems are emergencies, urgent or non-urgent, and why correct triage prevents airway compromise? Think in 3 tiers: emergency now, urgent within 48 hours, and non-urgent routine care category. Emergency can mean airway swelling or a knocked-out tooth. Urgent is lingering sensitivity, chips weight. Learn to spot emergencies fast: airway compromise, rapid swelling, toxic signs, uncontrolled bleeding, avulsion, fracture. Choose the right setting. Dentists deliver definitive care. Urgent care handles basics. ED stabilizes emergency. Minutes matter. Beyond 60 minutes, avulsed tooth survival plummets. Infections can quickly endanger the airway. Roadmap ahead: urgent signs, injuries, infections, bleeding, special populations, care settings, pain, antibiotics, visits, outcome. Emergency if Ludwig's angina signs, tongue elevation, drooling, muffled voice. Risks: airway collapse, mediastinitis, sepsis. Emergency if bleeding persists despite pressure, with dizziness, pallor, or after trauma. Anticoagulants raise risk. Dental trauma plus neurologic signs or jaw deformity suggests fractures. Prioritize airway and neurovascular assessment. PDL survival falls fast. Minutes matter. Keep the tooth moist in milk or saline. Permanent, not primary teeth. In children, prioritize the successor. Replanting risks: ankylosis, aspiration, soft tissue injury, and serious alveolar damage. Luxation urgency hinges on pain and function. Extrusions, lateral shifts, intrusions need care. Fractures next. Pulpitis gives lingering pain. Apical periodontitis hurts on biting. Abscess adds swelling and systemic signs. Urgent becomes emergency when infection spreads beyond vestibule. Adds systemic signs, trismus, or airway risk. Escalation flags include fever, tachycardia, chills, trismus, dysphagia, or drooling. Floor of mouth elevation, hot potato voice, elevated WBC/CRP, airway risk. Pericoronitis is inflammation around a partially erupted third molar. Emergency when spread, trismus. Systemic sign: dry socket arises 1 to 5 days after extraction. Lost clot, severe pain, urgent analgesia, not infection. Expect mild oozing for 24 hours. Persistent brisk bleeding or large clots need urgent assessment. Patients on anticoagulants may bleed more. Therapeutic warfarin is usually safe. Emergencies depend on severity. For appliances, poking wires, urgent discomfort. Loose brackets okay unless traumatic. Aspiration rare. Pain-free loss is low risk. Sharp contours cut. Large fractures with nerve exposure approach emergency. Ellis crown fractures. Eye cosmetic. 2 urgent dentin protection. 3 exposed pulp. Emergency infection risk. Root fractures. Mobile. Tender teeth. Alveolar. Segment moves. Red flags. Occlusion changes. Entrapment. Paresthesia. Facial fracture. Dental trauma with these red flags suggests mandible or midface fractures. Protect the airway urgently. After wide opening, mouth stays open, urgent for pain, intake. Monitor secretions, airway. Pediatrics next. Children differ. Primary teeth intrude or luxate, not replanted. Adolescents heal pulp better. Assess airway. Severe early childhood caries is urgent. Risks include infection, dehydration, swelling or fever warrants emergency. Immunocompromised and diabetic patients deteriorate faster. Spread, poor healing, lower emergency threshold with systemic symptoms. Pregnancy next. Urgent dental care is safe. Shield imaging. Treat infection. Prefer acetaminophen. Avoid late NSAIDs, even after hours. After hours, Choose site by need, definitive dental care, medical stabilization, or basic assessment with analgesics only available. NSAIDs alone or with acetaminophen outperform or match opioids with fewer harms. Next, antibiotic criteria. Use antibiotics for systemic or spreading dental infections. Avoid for toothache or drained abscesses. Overuse harms. Begin with targeted history, focused exam, and appropriate imaging to triage and plan procedures safely. For emergencies, we act definitively. Relieve pulpal pressure, drain abscesses, stabilize dental injuries, control bleeding. Imaging choices next. Match suspected injury to modality. Periapical for endo, panoramic for triage, CBCT, CT for timely surgery. Timing drives prognosis across avulsion, luxation, abscess, and bleeding, guiding ancillary decisions and expectations ahead. Contamination in dental trauma demands irrigation, tetanus verification, and systemic infection assessment. Delays increase complication. Missed dental emergencies can turn deadly, threatening airway, bloodstream, brain, bone, teeth, nerves unequally across communities. Dental problems comprise 1 to 2% of ED visits, 2 million, peaking after hours, reflecting access gaps. Dental emergencies, time-sensitive when life, airway, oral function, or uncontrolled pain or bleeding are threatened. Quick red flags: compromised airway, spreading swelling, fever with trismus, bleeding, avulsion, fracture, systemic signs. Use features to triage. Life-threatening means emergency. Severe localized means urgent. Minor means non-urgent. Let's bust myths. Most toothaches aren't emergencies. Don't replant baby teeth. Antibiotics treat infections only. Key takeaways: scale, time, critical avulsion, care, non-opioid analgesia, antibiotics used cautiously, safety next. In emergencies, prioritize safer analgesics and target antibiotics only when clinically indicated, judiciously. If breathing threatened, bleeding uncontrolled, infection spreading, or tooth loss imminent, seek emergency dental care. No true emergencies. Choose the right setting. Limited access drives evening, after hours surges.